The health impact of homelessness is often not recognised, and yet people who are homeless die young, often unsupported, and in unacceptable situations.
I go to bed every single night like you. I drink, I go to the toilet, I do absolutely everything that everyone else in the world does. The only thing that I don't do is lock my door.
I've been peed on, I've been set alight, kicked. You know, it's not safe out there.
I just think it's paramount that they have dignity in death.
People are often homeless because they've had really tough times in their lives. And sometimes, having had that experience, they lose touch with friends and family. Indeed, either through mental health problems or drug or alcohol addiction, those friendships and those family relationships break down. And sometimes people don't feel that they deserve support, but they do.
Homeless people die young. They don't die of homelessness, they die of treatable medical problems.
Homelessness is a health issue. It's a lot more than just an accommodation issue.
There's probably about 3,000 homeless people in and around the city of Manchester. Yeah, within that cohort, if you think of the average life expectancy, there's a lot of work to do, isn't there?
I really feel that they experienced the worst discrimination and judgment with regards their circumstances, one being homeless or experiencing any level of homelessness, and then not being entitled to the same level of needs that anybody else should be.
Their lives are very transient, they're very chaotic. They're used to seeing huge amounts of professionals for very short periods of time who do very short periods of work, maybe make quite grand promises that aren't always realised. And so they become very mistrustful, very closed off. They've often had extremely negative experiences of engaging with what might be termed the system or processes.
One of the things that we find is that people have often a combination of quite significant physical health problems with mental health difficulties and addictions. And it's not uncommon to find people who have end-stage liver disease, but also people who have high rates of conditions you would not normally expect in a young population, such as frailty, frequent falls, dementia and incontinence.
Because we know that people who are homeless have health issues, really complex health issues. We know that they're dying younger, they're dying 30 years younger than the general population. And they're not dying, although they do die of overdoses or accidents, actually they're more often dying of treatable medical conditions.
As a practice specialising in this, we can help them to understand why that's not necessary.
My name is Dennis Rogers and I'm a caseworker and I work for Groundswell. Well, a lot of people who've been homeless have had great jobs. They have worked. I've known a doctor, I've known solicitors, I've known actors who have got into addiction, become homeless.
30 years of heavy drinking and I was dying slowly. I knew it really, but it was always I'll give up tomorrow. I'll stop drinking tomorrow. But tomorrow never came.
Many of our patients, perhaps to look at, you wouldn't have any idea we're experiencing homelessness. Everybody has their own way of dealing with their situation.
I used to access services in different towns and just like, oh, I might be here for 6 months, you know, or I might be here for 3 months or something like that. And usually in the places, they would take you on for that length of time as long as you knew the service that you previously came from.
I just came, walked about, started learning things from other homeless people.
It'll be different for every person. I think you can think of like big reasons, the big scale reasons in society, like lack of affordable housing, inequality, poverty, unemployment, but then you can also think on an individual level that there's a lot of common routes into homelessness, trauma being a really big one of them. So often it's after a life event like a job loss, like a bereavement. A relationship breakdown is one of the biggest reasons people give for becoming homeless initially. Often people end up homeless because they're having to leave a situation where there's been violence or abuse in the home.
I've always had drug issues, but I always said that was self-medicating.
Yeah, I was homeless for about altogether 10 years in 2 bolts. Basically, my relationship broke down and I could have gone back to my mum's, but pride stopped me. She'd have took me in, but so I ended up sleeping rough.
So an ACE is an adverse childhood experience, and there's been lots of studies which have shown when people have experienced multiple ACEs, so they might be things that are quite common, like parental separation, financial difficulties, a bereavement, but also things like abuse and neglect, more serious events. When people have experienced kind of 4+ of those in their childhood, the statistics show that actually later on people are much more vulnerable to physical ill health, to developing mental health difficulties, and much more at risk of becoming homeless and developing kind of related issues like substance misuse, other forms of addiction.
And that could be the flip of a coin of losing your job, you know, relationship breaks down, drinking too much, or not even drinking too much, mental health collapses, and you find yourself in this cycle. You know, the message I would like to give is not every homeless person is a drug user. They're not an alcohol user.
I think that having good access to palliative care is massively important, and I think it's something that has previously been missed.
I believe it's important because everyone deserves the right to equality in care, and everyone deserves the right to die with dignity and respect.
I feel it's wrong to find bodies, if we ended up finding bodies on the street every other week, especially when it's been COVID.
I said I think it's important because some of these people have never had a voice, and it's important that they can get the point across and get the healthcare that they deserve.
You know, they are still human beings.
To particularly consider people who are experiencing homelessness in palliative care, because we'll often find that maybe in terms of other aspects of healthcare, they've often faced barriers or care hasn't been equitable, and so we have to make sure that at this point in their lives, we're absolutely certain that the care they're receiving is equitable and fair and is what they need.
So we passionately believe that everyone deserves the right to the care and support that they need at the time that's right for them and in a place that's right for them. It doesn't matter what community they belong to. It's really important that we offer the same services and that it's person-centred care.
Despite the fact that we have this very high need population with multiple complex needs, they very rarely got referred to or had access to any form of palliative care support. Now, the reasons for that are multiple but and complex, but we know that, for example, hostels and homelessness services generally are working to a recovery model. It's quite unpalatable to be thinking of young people potentially approaching the end of their lives. But in addition, we've got conditions which potentially people could recover from. So, for example, if someone has advanced liver disease secondary to alcohol, if they were to stop drinking, they could potentially recover from that. So it's very difficult to know and to decide when do you refer somebody to palliative care services.
Clients, I don't mean this wrong, but the clients are chaos. Yeah, and when the client's chaotic, they don't want to know about their health. So a lot of the time it's left, and then it's like when you find out what's going on, so like 6 months before, if I found a client maybe 6 months earlier, I might have been able to do something with them and actually get them to that service. But because they're so entrenched and they're so in deep in their own chaotic lifestyle, they might not want to engage. They don't want to know.
When you add to that mix the mental health difficulties and lack of wanting to access health services and barriers to accessing health services, you have a very complex mixture.
Whereas clients who sometimes are homeless, they won't get it because it's like, oh, well, they're too hard to find, they're entrenched, or when every time we come to the hostel, they're not there, and those sort of things. But it's actually split spending that time and actually trying to work out why they're not there, working out what's going on with that client, actually talking to the client, making sure that the client understands what their diagnosis is. It's the thing that I would look at, but then it's actually talking to the specialists in the hospitals as well, because like sometimes GP talk and doctors talk is all medical jargon, and it's like, okay, so the clients don't understand it sometimes. If you're talking to a client in medical jargon, the client's never going to understand that.
There's all these tiny little facets to it, what can be really challenging, having to then work with other agencies who maybe not, and no disrespect to anyone, who maybe are not as knowledgeable and know about the difficulties facing homelessness.
Some staff at practices literally just were not aware of what the current guidance is, despite all the publicity around it. I think I often describe it as if somebody is living, breathing, and is from planet Earth, they're entitled to primary care registration.
People experiencing homelessness are often dying very young, and they often have multiple and complex needs. They can't all recover from this, and we can't fix everybody's problems. So we have to be able to approach them in a person-centred way to help them explore what's important to them, what living well means to them.
It's not very realistic, it's not very fair, it's not very compassionate to expect somebody to change. We need to accept people for who they are, where they are, and support them in that. I think one of the only ways to do that is to provide care in an environment that's familiar to them. So upskilling hostel staff or creating environments within the homeless sector where somebody could approach the end of their life or die there. I would love to see that happen within my time in Manchester.
It all depends on that person because everyone's story is unique, but I feel a success would be respecting someone's wishes and making sure they die in the place that they choose to, whether that be in the hostel, their home, or a hospice, or a hospital.
I think it's about being looked after wholly. I think it's about getting the right medication and not self-medicating. Some people can get treatment and it can be helped, but if they don't go and seek the treatment, then the situation gets worse. We've had people have the legs off because they've not had the right treatment. So I think it's important that they're put somewhere where they can recover, where they can get the most appropriate treatment, and if not, then we seek the most appropriate treatment for them to die with dignity and respect and how they want to, because not everybody wants to go in a care home at the end of life, not everybody wants to go in a hospice at the end of life.
Living life well to the end means, I mean, I've got a daughter, a grandson. I hardly ever see because they live all the way down in Devon, which is a hard work for me to do. And I have to, with all my hospital appointments and meetings and stuff that I'm doing at the moment, it's very hard to get away. But I think what I really would like to spend more time with my daughter, and then hopefully my grandson. And I'll be happy.
Staff working in the homeless sector, that carry a huge and heavy burden when people aren't linked into services, if they're not registered with a GP and their health is going downhill in a hostel, it often falls to the hostel staff to actually care for that person. And you can just imagine, with no nursing knowledge, with no medical knowledge, that must be quite a terrifying thing.
You have to factor in quite a few different variables as opposed to, like, say, supporting someone in their home. You have to be mindful of other clients in the hostel, privacy, substance use, mental health, complex needs. You also have to take into account the staff as well, as some sort of like diagnoses such as cancer can be quite triggering to staff and may bring up past experiences. And also health and safety is a main factor because you want to make sure that that individual, if they're receiving treatment, has got the sufficient care and support that they need to be able to have that quality of life in whatever time they have left. It's all about promoting quality of life. if you focus on the deaf, you are abandoning that individual. So there's a lot more factors to take into consideration when providing support, and also trying to gain access to external services to come in and provide that support as well. So it can be a sort of a very, sort of like a juggling task.
Here at St Anne's, we sort of envisioned a different approach to palliative care in order to reach people who weren't traditionally accessing our services. So my role is an outreach role to go out into the community to reach people where they are, no matter where they are. That can be day centres, on the streets, it can be in homeless hostels, or in a flat if somebody's been given accommodation by the council. So it's really wherever somebody has palliative care needs, we will go to meet them where they're at.
So we offer care and support to anybody living with or affected by life-limiting illness. So that could be the person with a diagnosis of any life-limiting illness, or it could be their family, friends or loved ones who need support. And we offer support right from the point of diagnosis, all through their treatment journey and treatment plan, and to the point of when they die, and then look after their family and friends after that person has died.
We were delighted to be able to work as part of the twinning project, where we, at the hostel, the Dello hostel, were able to work jointly with the staff in St Joseph's Hospice, a local hospice. And together we were able to make a difference for our residents and the way we were able to support staff.
Being able to have the support from and the training from the nurses from St Joseph's Hospice has been pivotal, just in giving the staff team the confidence and the knowledge to support the clients to access treatment earlier.
The palliative care support and the knowledge, the information has really helped. I think through the guidance and the information and the support, I've been able to sort of guide the team as well in terms of palliative care. We need to respond as soon as possible, isn't it, to get the support in place.
It's a single homeless project. It's a very, I say small charity actually, we're pan-London, but we like to really pride ourselves about working with people who have experienced homelessness within the London area, and reach out to the most complex needs and support them in the community.
If somebody has palliative care needs or is in the last year of their life, accommodation is of course really important. And one model that we really support and we advocate for is the Housing First model. It is a model that gives somebody housing, but at the same time that enables privacy. It enables people to access care, to be respected in their own home, which is something that, again, when you ask people what they want to often be cared for in their own home.
And Housing First is very unique because it's about getting that person into a home and then providing all the wraparound support. The only responsibility the person has to have is holding a tenancy. Anything to do with housing, finance, money, benefit, the health is what we support them with.
But in terms of Housing First, look at the quantity and the quality of the outcomes. Look at the feedback, listen to what the people that we work with are saying about us, about Housing First, and then make a decision.
Having someone who can build a therapeutic relationship, build trust and be a constant source of support is so vital.
They are at that point where perhaps life is limited. They might not change how they cope with that pain or that distress, and we have to respect that that isn't something that's suddenly going to change. So we need to understand and meet people halfway, really.
And I've done the Health Now training, and that involved call and check while it was lockdown. We was ringing people in vulnerable situations or homelessness.
I've actually taken an 80-year-old guy when I first started who refused dialysis, everything else. He said, no, I don't need it. Why should I go for it? Yeah, it's like, I'm 80 odd years of age. He went, if I die, I die. It's like, okay, fine. Let's take you to a ward, a dialysis ward, and let you see it. So we took him, showed him it, and now he's still having it 7 years later, 7.5 years later, he's still having dialysis 3 times a week. I still see this gentleman, talk to him. And it's nice to see him and actually work with him still. But that's the side of things that are the nice things of it.
I work in the tri-borough, but I'm also known as like a floater. I could go whatever borough I'm needed in. I mainly work with the most challenging clients, and I work with clients who actually are in their own flats, which can be a challenge in itself.
I've not really had a homeless patient in the hospice before, so I think the staff felt a little bit of anxiety around that, kind of how he was going to be, if there was going to be any challenges with how he was going to be and how he'd kind of fit into the hospice really.
He knew what was happening, and he wanted to come back to St Anne's to die because he'd been, in an odd way, I think he'd been quite happy here, despite the fact that this was where he knew he was going. He was approaching the end of his life. He was happy because he was treated well. He could have a laugh with people, and that I don't think that had happened for many, many years.
How best to work with those individuals should be a question we should all be asking ourselves more regularly. And it's something that it doesn't need to be a difficult conversation. It's just, what would you like to have for yourself? You know, let's plan things, because you never know. And when it comes to working with people with ill health anyway, I'd argue it's a healthy conversation to have.
People in the homeless community, they've got a story to tell, and it's up to us to enable that equity of access so that we make it as easy for them as possible to access the services that they need. We don't discriminate against people within our population. If they need the service, then that's what we need to provide.
I think the way homeless healthcare is delivered nationally is inconsistent. There isn't a standardised approach to it, but what we do know is that there are homeless people everywhere. There are homeless people everywhere in the UK, and so therefore they need healthcare.
Well, we should never forget the homeless. You know, take a walk around the city centre where I go every day and just have a look around. The homelessness is as real today as it's ever been.
What's really needed is that we shift our focus, that we start considering involving palliative care earlier on in people's journeys. We need to recognise that not everyone will recover, so we need to be thinking much more about bringing the multi-agency support to where people are earlier on in their journeys. And that trigger for action should really be when frontline homelessness staff or others working with someone are concerned about someone's deteriorating or advanced ill health.
Many homeless people in this state have no access to healthcare, no access to palliative care, and we have to change that.
I like to make people laugh and smile because that makes me happy.